Now we're going to talk a little bit more about kind of internal structures that are going to cause some of these emergencies, and this is where we can have some kind of internal bleeding or hemorrhaging, and this one would be the ruptured ovarian cyst, and this is a fluid-filled sac attached to the ovary. Again, this is when the ovary is creating an egg that's being ready for release into the fallopian tube. It can contain an enormous amount of fluid, and in some cases it may be so large that it needs to be surgically removed so that there's not such a significant amount of damage if it was to actually rupture. The internal bleeding is a rare complication, just purely due to the fact that this is something that's kind of built up around the egg cell. Ectopic pregnancies are true life-threatening emergencies, and this is when a pregnancy implants outside of the uterus, right? Very often pregnancy develops outside of the uterus when the sperm cell and the egg cell meet in the fallopian tube. It's just whether or not this implants into the fallopian tube, and then as cells divide and reproduce themselves, that fetus is growing at an exponential rate. And again, the lumen diameter of the fallopian tube is only able to stretch so much before it's going to actually rupture. Because that is a blood supplied piece of tissue, there is going to be internal bleeding. This is often accompanied with abdominal pain, and it can include previous surgical adhesions, the PID, a tubal ligation, which is the term for having their tubes tied, an IUD placed in the cervix. The rupture of a fallopian tube can lead to life-threatening bleeding internally, and should be treated as a true life threat. So we're going to have to cover the vaginal bleeding. This can be the simple manifestation of a normal menstrual cycle, or it can be something as extreme as a ruptured uterus. There are many causes to vaginal bleeding, and some of that could be as something simple as a spontaneous abortion, which is the other term for a miscarriage at under 20 weeks of gestation, the onset of labor, PID and infections, and then there can be lesions from previous surgeries or adhesions that have tears. There can also be any plethora of traumatic causes that create vaginal bleeding. One of those would be a straddle injury, and this is the injury from a blunt strike to the genitalia of a female, such as a girl striking a crossbar on a bicycle, some kind of blow to the perineum, or a blunt force to the lower abdomen. Foreign bodies inserted into the vagina, this could be willing or unwilling, and then a abortion attempt that perhaps didn't go so well, or a soft tissue injury in the general lower abdomen or vaginal area. One of the other gynecological emergencies could be postpartum eclampsia, and this is after the baby is born. The mother is at risk for eclampsia, and eclampsia is defined by hypertension and seizures. A thorough history is important, and if you have a pre-eclamptic patient, which is a patient who is significantly hypertensive in any stage of pregnancy, they are at risk for eclampsia, which is again that seizure associated with the hypertension while pregnant. Paramedic backup is almost always required. And again, what I want the students of this class to remember is that you should always be looking for an ALS intercept, and if you can reasonably make it to a hospital before you would get that ALS intercept, the most appropriate thing to do is to transport your patient, right? We're never going to wait on scene when we could be making our way towards the definitive care. If you can get that rendezvous in a reasonable amount of time where it's not going to delay you enough that you're going to cause harm to the patient, then the ALS backup is appropriate at that time. Okay, so unfortunately we're going to have to talk a little bit about sexual assault, and the CDC reports that nearly 1 in 3 women and 1 in 8 men will experience some kind of unwanted sexual contact in their lifetime. It's unfortunate that it's actually that common. There's not a very reliable statistic in what the overall number is per year. It seems to fluctuate from year to year. The big take-home points on this is that really at that point, when we're making contact with somebody who's suffered sexual assault, the biggest thing that we're there to do is to provide them compassionate treatment, right? And in some cases, this is going to be kind of difficult if you're a male provider dealing with a female who may or may not want other males to be around her at that point in time. And our biggest thing that we're going to do is transport them comfortably to an emergency department so that they can have the considerable care that they're going to need, be that physically or psychologically, after the event. Some patients may have multi-systems trauma, and you may actually have to treat them medically for some kind of shock or other component. When we're dealing with a patient assessment, we really don't want to make some kind of specific diagnosis in the field, and that's not really our job. The idea should be that we're obtaining an accurate and detailed assessment so that we can kind of filter our way through and figure out where we're at. Is this a life threat at this particular point in time, or is this just an acute emergency that's not necessarily life-threatening but may require some significant treatment from a provider in the hospital? We want to know how sick is our patient and whether or not we need to initiate some kind of life-saving measure, which would be including some kind of invasive procedure like IVs and significant amounts of fluid being delivered to that patient. Anytime we're dealing with a gynecologic emergency, if there's significant amounts of blood or body fluids, we want to make sure that we are safe with PPE and that they're seen safety. We want to always try to understand what the nature of illness or the mechanism of injury is, because the general dispatch information may be vague at best, and we might not get that clear picture of what's actually happening until we get a detailed patient history. So anytime that there's some kind of significant bleeding involved, you should consider having a need for law enforcement there, just due to the idea that it may have some kind of component of violence involved in it. And until we get there and figure out what's going on, that's generally a safe assumption. Again, with your primary assessment, we're making that general impression. Are they sick or not sick? And this is going to be based on your across-the-room mentation check. Are they alert and oriented to your presence? And if they are, do they have some kind of increased respiratory drive? If they're breathing normally and they're alert and oriented, they're probably a little bit lower on your radar for sick versus not sick. This does not mean that you get to hang out and have a good old time like doing your assessment on scene. Again, these people have called 911 for a reason. They are reasonably requesting some kind of transport to a facility that can actually take care of their medical needs. So we're going to assess ABCs, make sure that we're making a transport decision, and then move them farther on. After we've made that transport decision, we want to make sure that we're going to roll into history taking and a secondary assessment. And so without beating the dead horse, I'm not going to go back through all of these history taking questions, but we want to get a good sample history, and then we're going to lead that down through OPQRST, because for the most part, most of these things are either abdominal pain or genitalia pain and may or may not involve some kind of bleeding. Our physical exam is going to always protect the woman's privacy and modesty. We're going to focus on that nature of illness and the chief complaint, and then the only reason that you're going to visualize that is if it's absolutely critically necessary, or you're trying to assist with soaking up some kind of bleeding at that point. If the patient reports that there was syncope involved, that means that that patient should be treated as shock and that they've lost enough blood or they have a significant amount of hypotension involved. Vital signs are always going to be part of your secondary assessment with this patient. We're going to make sure that we understand hypotension and whether or not there's internal bleeding that's coming as a result of that. And if they have tachycardia and respiratory changes, that's generally a pretty good indicator that this person is now in a shock-like status. And if they are bleeding or there's significant discharge, we at that point are going to expose and examine that abdomen and the genital area. I'm not going to talk too much about the monitoring devices. This is just your pulse oximetry and, obviously using your primary assessment features of a blood pressure cuff and a stethoscope, right, for that detailed assessment. We're always going to recheck our patients. The idea is to see if they're trending, and that's whether or not they are going to trend upwards, as is if they're improving or if they're decompensating. Documentation is paramount to everything that you want to do, and you're going to communicate all the relevant information to the staff at the receiving hospital. And then make sure that in the cases of sexual assault that you carefully document everything, including the injuries that are observable and the patient's statements to you into the back of the rig. Anytime we're dealing with body fluids, we want to take standard precautions, which is your PPEs, right? And that could include iPro, some kind of mask, gloves at minimum, if not some kind of gowning. You're going to address your ABCs, and if there's signs of shock, again, we're going to establish that IV, and we're going to titrate fluid to a appropriate blood pressure. We're going to treat any kind of physical injuries that we see appropriately while maintaining some dignity and privacy. When we're dealing with serious bleeds, we're going to place absorbent dressings against and around the vagina, right? We're never going to insert anything into the vaginal canal. And you're going to try to keep count of how many different pieces of gauze or padding that you are using, and you are going to ask the patient how many pads they may have used, if they're using some kind of menstrual pad, prior to your engagement with them, because there is a noted amount of fluid that can be absorbed by a typical pad. If there's a possibility of pregnancy, we always want to include the idea that there may be an ectopic pregnancy, and these patients are all going to need to be evaluated by a physician. Transport your patient to the most appropriate facility that's close. We never want to bypass a hospital if they're bleeding. That is appropriate or can absolutely help you in facilitating their management. If ALS needs to be called or rendezvous with them, make sure that you know where they're at. And again, I'm going to touch on this one more time. We're never going to delay our treatment or transport of a patient waiting for ALS if the appropriate facility is closer than that rendezvous. Try to make that an intercept to where you're going, not waiting or actually moving away from the appropriate facility to rendezvous with that ALS unit. Always, always, always going to try to maintain the patient's privacy and modesty as much as possible. Again, only visualizing the genital region of your female patient if absolutely necessary due to some kind of bleeding or traumatic injury that you need to tend to. As with any other chapter, if you guys have questions, the appropriate means to address those is either via email so that we can create a class discussion or bring it up while we're in lab. We generally try to come up with at least 1 or 2 scenarios where we're dealing with something like this so that we can kind of get into the practice of behaving like professionals and understanding what the treatment algorithms are going to be.